So what I'm going to do is walk you through the psychological therapies. It's a very broad topic, so I can't cover anything in detail, but I thought I'll at least get you to the basics so that we have a grasp of what we are talking about. Later, if you're interested, I can concentrate on one or two therapies and look at it in detail. Okay. So today you're not going to learn any techniques, but at least you'll get a overview of what we are talking of when we say psychological therapies. Sometimes we call it psychotherapies as well. Both terms are synonymous. Sometimes psychotherapy can mean other than behavior therapy, but when you say psychological therapy, it includes behavior therapy as well. But if you say strictly psychotherapy, that would then be only the what you call the talking therapies. However, today I'm taking a broad view. Okay, I'm just sidestepping for a moment from the topic, but it's relevant. Now, I don't know whether you all have heard of this gentleman. Most probably not. But strangely, he's the author of what they say, the most cited article in the medical literature. And having said that, nobody seems to know about it nowadays. It's called the Francis Peabody lecture as it is called. The original appeared in the Journal of the American Medical Journal, or JAMA as it is called. JAMA is still going. This is nearly 100 years ago, 1927. Okay. So it's not 80 years, it's actually 100 years. So what happened was Peabody was asked to lecture to the Harvard medical students on their first day in medical school. So Peabody was a brilliant physician, quite young. He was in his early 40s. So he gave this lecture called The Care of the Patient. Care of the Patient. Okay, he was not a psychiatrist. But these are some of his memorable kind of quotations from the lecture. I would encourage you to actually have a look at the entire lecture. It's available on the internet. So what he said was he was referring to patients with functional symptoms, as they call. Remember this 100 years ago when we didn't have the concept of somatic treatment as such. So he said, so the successful treatment or managing of that depends on our insight into the patient's character and personal life, which you must appreciate and consider if you would be a wise clinician. It's not only about symptoms and signs, but it's also about the patient's character and personal life. And he went on to say, and this is his most quoted para from the lecture, he finished with that. He said, the good physician knows his patients through and through, and his knowledge is bought dearly. Time, sympathy, and understanding must be lavishly dispensed. But the reward is to be found in the personal bond which forms the greatest satisfaction of the practice of medicine. So he's referring to the doctor-patient relationship, which you can't establish with limited time. It takes time. And one of the essential qualities of the clinician is interest in humanity. For the secret of the care of the patient is in caring for the patient. I hope you got that double meaning kind of thing. So this title is caring for the patient. So to care for the patient or to care for the patient. Now that is almost like the mission statement for psychotherapy. So psychotherapy needs time. You can't really rush it as such. And there comes the problem, I suppose, in a busy day. Where do we find that time? That's something you'll have to work out. I'll come back to Francis Peabody at the end, because there was also something when he went to give this lecture, there was something that he didn't tell anybody. Kind of he kept it a secret, but that are relevant to the topics. So I'll keep it till the end. Okay. Like any good story, you must not tell the entire story at the beginning. So let's keep going. So because of that, it's not only in Sri Lanka, but all over the world, there's a significant decline in the provision of psychotherapy. So there's a decrease in the number of psychotherapists and a corresponding increase in those specializing in what we call pharmacotherapy, psychopharmacotherapy. And also there's a tendency for the therapies that the psychiatrists used to do to non-medical therapists, such as psychologists, occupational therapists, and social workers. But even in Part 59, I think that is there. It's not a bad thing. I'm not saying we shouldn't do that. But we should not hand over completely what we should be doing to them. That is, in a way, giving away part of our unique heritage to somebody who's not a psychiatrist. Okay. Why are we doing that? We are not pharmacologists. Primarily, our heritage is in psychotherapy, isn't it? And is it not important now? I think that's something to think about. So we'll come to that. Now, of course, when people decided on what you call the core competencies in medicine, we often refer to the kind of the CANMAT kind of guidelines. And that's accepted all over the world. Even when you come here to Australia, they would look at the core competencies. And even in the PGM, if you look at your prospectus, it's built around the core competencies. Okay. How do I know that? Well, I put it there. So it's there in the first page, the core competencies of a MD psychiatric graduate. So patient care, medical knowledge, interpersonal communication skills, practice-based learning, professionalism, and system-based practice. These are the 6 core competencies, which were laid down in 1999. And it should be part of all postgraduate programs all over the world. Okay. It is in your case as well. And most of these skills, if you look carefully, comes into psychotherapy. Okay. Number 3, definitely, interpersonal and communication skills. Patient care would definitely overlap significantly with psychotherapy. If you don't do psychotherapy, you can't actually have the core competencies. And then, of course, the American system is quite good. They train really well. One of the best psychiatry training is in the USA. So they want everybody to learn 5 psychotherapies. Okay. So they have a book for each of these psychotherapies. And all fellows in psychotherapy or board certified members must be competent in all 5 psychotherapies. The books are available. In fact, many years ago when I talked about this to Haris and Jan, they got down the books to the NIMH library. It's there. There's a book for each of these. Have a look. So long-term psychotherapy, supportive psychotherapy, cognitive behavior therapy, brief psychotherapies, and psychotherapy combined with psychopharmacology, which I suppose sounds the most practical for us these days. Okay, so let's leave it at that. That's the international scenario, the background. Let's look at the specifics of psychotherapy. Okay, what is psychotherapy? What do we understand by the term? Is there a definition or one sentence definition? Well, people call it the talking therapy in lay language, but it's a bit more than that. So Anthony Storr, who was a psychotherapist in Oxford some years ago, he defined it as the art of alleviating personal difficulties through the agency of words in a professional relationship, personal professional relationship. Okay, so all 3 are important. So the art of alleviating personal difficulties through talking in the frame of a professional relationship, a personal professional, as he called it. So a friend having a chat with you is not psychotherapy, okay? That's different. This is in a professional relationship. So there are certain boundaries and techniques which are common to all psychotherapies. However, when you talk of psychotherapy to people, lay people, they think of it as something like that. What we are thinking of is psychoanalytic therapy, where somebody is on a couch and nothing much is happening and both are sleeping, I suppose. Not quite true, but anyway, that's the perception we have of psychotherapy. But psychotherapy is older than Freud, actually. It goes back to an Arab physician called Al-Razi, famous man, 1865 to 1925. So that's many, many years ago. He actually talked about psychotherapy way before Sigmund Freud. But for the father of psychotherapy, I suppose, or founder of what you call psychoanalysis or psychoanalytic psychotherapy is Sigmund Freud, without doubt. He is the man who laid the foundation for thinking about the mind. His kind of concepts or his models were probably all wrong. They had no scientific basis. But he's the man who started thinking that there's something beyond the superficial kind of observations of the mind. So in that sense, he was a pioneer. And he worked with his good friend who was a neurologist called Joseph Breuer. Now, they were working and living in a country quite different to now. So they were both practicing in Vienna, in Austria. At a time when it was a part of the Austro-Hungarian Empire, it was different to what it is now. So it was a kind of in a way, a prosperous time as well in Vienna. So Joseph Breuer was a very highly paid neurologist who treated the wealthy, and he was very wealthy as well. And Freud was young. He was young and he didn't have much money, but he was quite bright. So Breuer had this interesting patient called Bertha Pappenheim. We know her as Anna O. How did Bertha Pappenheim become Anna O? If you look carefully, what Freud did was he anonymized the people who referred to by shifting it one letter in the alphabet. So Anna became Bertha and O became, or Pappenheim became O. Got it? So this lady was known as Anna O. Her real name was Bertha Pappenheim, which was revealed only very much later in life. So she had a whole heap of neuroses. She went into hysterics, thought she was pregnant, and was a real problem for Joseph Breuer. He was Joseph Breuer's patient, not Freud's patient. Freud never treated Bertha Pappenheim, actually. So Joseph Breuer was quite upset because this lady thought she was pregnant by Joseph Breuer. Of course, it was not true. He was a very upright physician, but it created a lot of problems with his wife. But Bertha Pappenheim was a very beautiful lady at the time. And of course, the treatments happened at home. In those days, the chambers were at home, not outside. So who visited the family knew. So Breuer became very upset and went to his young friend and said, what am I going to do? Now she's saying she's pregnant by me. So Freud, of course, was much bit sharper than that. He said, look, I don't think you should worry. I think she is actually not referring to you as a person, it's somebody else. And that's when Freud identified this thing called transference. So keep on, keep going. Don't stop the therapy. But Joseph Breuer lost his nerve and immediately terminated therapy. And it is said that he went on a second honeymoon with his wife to consolidate there. relationship. And he didn't see Bertha again. Freud didn't treat her either, but then remarkably she recovered completely and became a well-known social worker in Germany. And there's a postage stamp in her honor now. You can see the stamp. Okay. How she recovered, we are not sure who treated or what happened. But she became an eminent social worker in Germany. Well, so that's the story of that. However, Freud and another of his colleagues had another interesting patient called, Sabina Spilrain, Russian. She was a psychotherapist herself. And that story I won't go into now because it will take too much time, but very interesting. If you want to really go into that, you can read the book, or more accessible would be the DVD. There's a film called A Dangerous Method. All psychiatrists should see that. It's available on DVD. I'm sure you'll find it on YouTube as well. Okay. So it's based on the true story of how they psychoanalyzed Sabina Spilrain. She recovered as well, but had a sad ending because she went back to Russia and carried on her work. And when the Second World War came, she was in the Ukraine actually, and she was killed by the German SS because they thought she was a spy. Well, that's another story. Anyway, watch the DVD. Okay, let's look at dynamic psychotherapy. That's the kind of our foundation. It's another term for analytic psychotherapy, but we now call it psychodynamic psychotherapy. And all these key terms were kind of brought into effect by Freud, Sigmund Freud, okay? And his daughter Anna Freud, but mainly Sigmund Freud. So the terms free association, defense mechanisms, transference, countertransference, resistance, and of course dream analysis. Freud wrote an entire book on the analysis of dreams. All his ideas, okay. I won't go into each of these, but as trainees, you should know the definition of each of these terms, okay? Even though we may not be using these nowadays, other than, I suppose, the defense mechanisms. There's nobody in Sri Lanka who practices dynamic psychotherapy now. When we were registrars, there was one person who practiced, old psychiatrist called JSP Abeyavardhana. He practiced dynamic psychotherapy. He was a student of Anna Freud. Yeah, he was trained by Anna Freud. And of course, Anna Freud was trained by Freud himself. So JSP Abeyavardhana, I think, had some training with Harishchandra as well. Harishchandra, Dr. D.V.G. Harris, he also worked in the clinic where Anna Freud, she set it up actually in the UK. So there were some links to them, and then they taught us a bit of analytic psychotherapy or psychotherapy, dynamic psychotherapy. But there are no practitioners left in Sri Lanka now, okay? So it's dead, extinct. However, the principles of dynamic psychotherapy are supposed to be understood by all, and even the Royal College here insists that all trainees do a long therapy of one patient, okay? Long therapy means 40 sessions. So if you are hoping to work here, then in Australia, you should have done a 40-session therapy with one patient. Right, anyway. Let's go on to so what happened was in Freud's time, Freud saw patients every day. He saw them almost every day during the weekdays. So one patient every day for 1 year or 2 years. And I don't know how he saw enough patients to earn his living, but anyway, so he couldn't have seen very many patients. But then it's not practical nowadays to see one patient every day for 2 years. Nobody can do that, I suppose. So what happened, they cut it down and called it brief dynamic psychotherapy. So when we started training in Oxford at that time, they had a 6-month registrar slot. So this is like here. So we had the opportunity of being a registrar in psychotherapy for 6 months. And in that 6 months, we had to see 4 patients, hoping that at least 1 or 2 will stay on for the entire 6 months. So that's all we did. 6 months, 4 patients. We saw them every week for 1 hour. And we had 1 hour of supervision for every hour of patient time. So 4 patients, 4 hours, supervision 4 hours, 8 hours a week. That was it. No on calls, at least not during the daytime. So it was one of the best appointments. So there were only a few people who had the privilege of doing that appointment, and that was myself and Dr. Upali Piris, who is now retired. But anyway, so the 2 of us had the privilege. So it was a popular appointment, as you can see. 8 hours of work a week, and people took it up before the exam. So they were not happy about that anyway. So that's how it went. So 6 months, brief dynamic psychotherapy. We practiced the same principle, but it was all cut into 6 months, mean not 6 months, it's less than 6 months because it took a few sessions to get them into therapy and to terminate another few weeks. So it was actually about much less than 6 months. Can you make a change in 6 months? Well, in psychotherapy, dynamic psychotherapy, you are never sure whether anything has changed. It's a speculation. And so we don't know. All I can say is that it was interesting and something happened. So that's the problem with it's not defined like CBT or behavior therapy where I have a clear end goal. Here, there's no end goal. You go on as long as the patient is satisfied, or we have a limit because the service says you can go beyond 6 months. Okay, at 6 months you have to finish. That's it. So the brief dynamic psychotherapies became popular, and they became shorter and shorter. So mainly they were aimed at people with low self-esteem, difficulty in making relationships, emotional disorders, sexual disorders as well. Patients needed to be a bit insightful and willing to make links between the present and the past. So that ability, or what you call psychological mindedness, was necessary. Otherwise, we didn't take them on for therapy. So they assessed, and then only the suitable people were taken on. Okay. So not everybody was taken on board. So basically, these are the principles of brief dynamic psychotherapy. We focused on one area, unlike Freud, who covered the entirety of the personality. In brief, you can do that. So we asked, okay, what's our main problem? And what's happened before, and kind of the history as related to the problem, not the entire thing. And then we identify the common themes. And then we identified similar issues arising in the present, which were similar to the past problem. And then we made a connection between the past and the present. When we say we mean the patient and the therapist. And that was called interpretation. And these repeated connections established between current behavior patterns and the past behavior patterns help the patient to make changes and become more adaptive in their way of living. So that's very briefly what we did in brief dynamic psychotherapy. So the transference was actually encouraged, but not the counter-transference. So transference was necessary to show the patient that what happened in the past is now happening in the present with the therapist. Okay, so the transference was used for that purpose. But you have to be careful because, we didn't work with paranoid patients, because obviously if somebody paranoid became, paranoid in the session and thought you were the cause of their problem, that could become quite dangerous. And so paranoia was an immediate exclusion. Okay. Otherwise, you can end up with a serious problem. Right. Anyway, but of course, very experienced and kind of brave therapists did take on paranoid patients at their own risk, of course. Okay. So now we are kind of, unfortunately, we don't do that kind of thing, but I suppose at least one patient you should do with a bit of psychodynamic angle. That's very important for our training. So anyway, it's up to you. So now we go on to the more newer and the more kind of, well, scientific, shall we say, psychotherapies or psychological therapies as they are called. And they are basically divided into two groups, okay, the behavioral therapies and the cognitive therapies. The behavioral therapies are, the pioneer was this person called B.F. Skinner, and it's all based on learning theory, what you call conditional conditioning. I think you know the two types of conditioning, operant and classical conditioning, going back to Pavlov and all that sort of thing. So basically, Skinner identified that some human problems can be treated by deconditioning or reversing the conditioning, mainly using not quite classical, but operant conditioning. Okay. And those techniques are quite powerful with some of the problems. And even now, the therapy that should be used, the first line therapy for some disorders is behavior therapy, not psychotherapy, not dynamic. For example, OCD, obsessive compulsive disorder, the recommended therapy is not CBT, it is ERP, exposure and response prevention. And for all phobias, it is graded exposure. You don't do CBT for graded for phobias, okay? So they are still very important. And what happened was, for every behavior under the sun, they developed a technique. So there's this huge book of 1,000 pages called the Behavior Therapies, which gives a description of all the behavior therapies you can think of. Okay. If you will Google, you will find it. Not many people use it now because other therapies are superseded, but it's still sort of interesting book to read. So B.F. Skinner, and he of course thought behavior therapy could solve any problem, and he said basically give me any person, and I will make him whatever you want. I can make him a criminal or a saint or a doctor or whatever using behavior therapy. Of course, that was an extreme statement. I don't think you can make anything out of anybody. I don't think that's possible. But anyway, he was quite confident that you could do that. But of course, people later added on the cognitive component, and then that became CBT. So CBT means cognitive behavior therapy. So cognitive therapy includes behavior therapy, and that was combined. And the pioneer of that was actually not Aaron Beck. There was somebody who came before him called Albert Ellis. He was not a psychiatrist, he was a psychologist. And he was the founder of what we call rational emotive therapy, RET. And he was actually came a bit before Beck. So most of his, kind of similar to Beck, but there were differences. Again, I won't go into that today. But look up RET, you have to know these kind of little differences. And he was a very aggressive therapist. There are some videos which maybe I'll show you later one day, where he does therapy in very, very short time, but very, very confrontational kind of therapy, where he questions whether people should get upset with anybody or anything, because why should you? People are free to behave as they want to. And why would you get upset about that? That was his kind of view. And he made a therapy out of that and became quite famous. Of course, the person we know more than Albert Ellis is of course, Tim Beck or Aaron T. Beck, who founded cognitive therapy. Well, you can't say founder, but he was I suppose, the main founder of cognitive therapy. But before that, there were people who kind of used the same principles. So Aaron Beck, and now, of course, his daughter is carrying on the work, Judith Beck. And I think all of you know Aaron Beck. And I hope all of you all know cognitive therapy as well, his fundamental treatment for depression. So firstly, it was for depression. It was called cognitive therapy for depression. And after that, it has expanded into every possible condition under the sun. And you can even now treat schizophrenia with cognitive therapy. Previously, we were told never to treat psychosis with psychotherapy or cognitive therapy or anything, because that would be quite dangerous. But now we do. And that came quite late. Anyway, so just to kind of, there's something I think I need to just tell you about this difference between psychotherapy and counseling. It's an eternal problem because counselors don't want to be called kind of psychotherapists and vice versa. And in the past, the psychiatry textbooks didn't have a chapter on counseling. There was no chapter on counseling. But then suddenly a chapter appeared on counseling in the Big Oxford. It's there now. And if you look it up, there's a chapter on counseling. And it's written by a psychotherapist. In fact, it's written by the psychotherapist who was the junior psychotherapist in Oxford at the time, Mike Hobbs. I don't know whether he's still there, but look it up and see. So what is the difference between psychotherapy and counseling? Well, basically, there's a fundamental difference. One, counseling is, advice and sympathetic listening and problem solving. It doesn't use the transference or any of that. It doesn't use the doctor-patient relationship for change. Okay. Whereas psychotherapy, the doctor-patient relationship is of crucial importance for change. You may not call it transference, but it is utilized as a part of the therapy. And when I say psychotherapy, I don't mean behavior therapy as such. I mean more the psychotherapy proper. Okay. Behavior therapy, we don't use the doctor-patient relationship as such to leverage the therapy directly. Of course, it's important that the patient complies or so that we establish a good rapport. That's not what I'm talking about. So anyway, these terms overlap. So obviously you can't say, well, you are a counselor, you should not do psychotherapy, or you're a psychotherapist, you should not do counseling. It depends on what the patient needs, really. No need to get into a slot and say, look, I can't do that or this. A psychiatrist should be able to do the entire thing. That's the importance of being a psychiatrist. Okay. You're qualified to do any model. And that makes you different from the other people, the non-psychiatrists who also practice in mental health. They are important. But remember, they are trained in one model. You are trained in all the models. So you have a wide range of options so that you can see and mix and match to the patient. Other people can't do that. So in a way, you can kind of refer to the correct person who may be specialized in one, but you have an overall view of everything, or should have. I think that's the important thing. Now, if you want to kind of categorize psychotherapies, basically, there are what you call the basic procedures. I think Oxford gives this the best. If you look at the Oxford, it classifies this in a very sensible way. So it says, look, there are basic procedures which are common to all psychotherapies. And that involves a lot of communication skills practices. And the next stage, you can kind of stack it on a level of complexity. So the basic procedure, which should be done by all doctors, not only psychiatrists, maybe even the supportive part of treatment should be done by all doctors. Problem-solving techniques can be done by counselors and psychiatrists, and then going on to behavioral and cognitive treatments or a combination thereof. Psychodynamic methods are separate and is at our discretion. But to understand psychodynamic kind of principles is important in the practice of the other techniques as well. Or understanding a patient, you should have some knowledge of psychodynamics, okay? Even if you don't use it as the therapy. So what do I mean by basic procedures? So basic procedures are actually the communication skills, which were taught to you in the behavioral sciences, if you're in Colombo. So the doctor-patient relationship, listening skills, expression of emotions, information, explanation, advice, improving morale, and encouraging self-help. So these are the basic foundations of any psychotherapy. Okay, without this you can't do psychotherapy. So all doctors are hopefully taught in these basic procedures. So in a way, you all have been taught the basics of psychotherapy at your MBBS, even though you didn't really know it. So using the doctor-patient relationship to gain the patient's confidence, improving compliance, or nowadays we call it adherence, and sustain them through periods of distress. Okay, that's a basic procedure. I'm just quickly going through the basic procedures. Okay, you will have to look this up later. Listening is enormously important. And everybody knows that if you listen, that goes a long way in therapy. So if you don't know what to say, you can just listen. And that's what Freud did actually. He just listened, or at least he appeared to listen. And he didn't even sit in the visual field of the patient. He sat behind the patient and listened. That's all he did. He didn't even make an intervention. Adequate time, of course, within the boundaries of practicality, nonverbal signs, and rephrasing. So these are the skills of listening. Again, time is short, so I won't go into each in detail. I missed one. Yeah, expression of emotions. Now, emotions are, of course, quite an important aspect of talking to patients. Patients are in distress, that's why they are called patients. Patients mean one who suffers, so obviously they are in distress. And if you are in distress, how do they show distress? By emotions. So all doctors must learn how to manage emotions and not be afraid of emotions. When we say emotions, we mean the negative emotions, of course, mostly. So patients are ashamed also sometimes of showing weakness, especially the males. So ventilation is important, but not too much also. So there's a limit to ventilation. If you allow too much ventilation, that will impede the progress. So how do you decide on that? Just giving information, explaining and advising, that's also part of psychotherapy. Okay, so don't think that is not psychotherapy. So telling patients about the facts about the illness and what they can do, what they shouldn't do, and what will happen. All the 5 things that Neil told you about, that's all a part of the psychotherapy as well. Okay. And improving morale, very important. Most often we are giving not very good news to people because they are coming with the illness. But you have to put it in a positive light by telling what can be done rather than saying what can't be done. And lastly, even if there's no hope of cure, there are ways of reducing pain and distress, and also how to optimize the abilities they have. That can be done, okay? Even in dementia, that can be done. So that's all a part of psychotherapy. So now you'll understand that you are doing psychotherapy now, even now, but not in a structured way maybe, but the basic procedures are being done. And of course, encouraging the people to do as much as possible for themselves is very important, and not allow a dependent relationship where they keep coming and coming and coming. So seeing somebody for 10 years is not a virtue. It means that the therapy is not really going well. In fact, in the briefer therapies, there's a time cap of 6 sessions. For example, in solution-focused therapy, the absolute maximum is 6. That's it. And the patient is told whatever happens, it will finish in 6. That in a way also generates the kind of tension the patient needs to work faster. When you say, okay, 6 and that's it, after that you're on your own, that encourages improvement. Okay. Okay, I'm not going to go in detail on this because time is short. So anyway, the problem of excessive dependency has to be addressed. And if there's dependence, you need to question your personal life as well and what you are doing to prolong the contact. Something's going wrong there, okay? And that's why if you're in psychotherapy, kind of, you need another person to monitor. So that all psychotherapists who are even the experienced people, they have a mentoring psychotherapist whom they talk to once in 3 months or whatever, because that's important so that you don't go wrong and without knowing drift into not very professional relationship. That can happen easily to anybody. So you need a bit of safeguard. This is just a basic thing which I tell all student registrars when they come, and that's in your from your medicine book, the one that we ask you to read, Communication Skills in Medicine. So basically, there are 3 ways of sitting at a table, and the best way is B. So if you are right-handed, the patient is on your doctor, on your right here. That's right. If you are left-handed, patient is on your left. And if you practice that, you will see that that's the best way to write and also look at the patient. Otherwise, you lose contact. Okay. So that's a very basic thing. And I always, when I sat in the clinic, I used to tell people, look, I don't think you're sitting correctly. Make sure that you arrange your chairs. Even though the clinic is crowded, you can still get it to some degree of, And of course, if the table is not there, that's even better. But then, of course, we need to keep our records. So that's a very simple thing you can do. And that in itself makes a huge difference to the interview, demonstrated with scientifically. Okay. So that's one little thing you can do. Next time you sit down with a patient, make sure that you got it right. And insist that it has to be right. Because sometimes when you are asked to go to another place, you will find that the tables are fixed and you have no choice. You're in a room where you have to sit on the wrong side. So I have gone to the extent of changing the room and saying, look, I can't work in this room because it's the wrong way around. And they have obliged. It's up to you. Okay, so let's look at the simplest therapy. It's called supportive therapy. I'm going to go a bit fast, but supportive therapy basically means that that you use when there's no other treatment possible or necessary. Short-term distress in the early stages of treatment to sustain a patient who has an untreatable medical or psychiatric problem or stressful life events that cannot be resolved. Usually it's about 15 minutes, okay? So when we say in the ward, we ask somebody, okay, can you have a quick chat? Or we normally give this part to the non-doctors, but they can do it. That's what you are doing, supportive therapy or supportive treatment. But you have to use it appropriately. Not every patient should be sent for supportive therapy, okay? So these criteria are there to help you decide, okay, which one is suitable for supportive therapy. Right. Next level is problem-solving therapy. And that is the problem-solving therapy as described by 2 people. I won't go into that again. There's Goldfried and another person, Zurila. It is Zurila and Goldfried. So they said you can have this therapy in 6 levels or 6 steps. So you list the problem. The patient chooses one of the problems. You discuss alternative courses of action the pros and cons of each, choose one and do it and see whether it works, and look at the results, evaluate, and if it has not worked, you go back to step number 2 and choose the next solution. Okay. Step number 3, actually. You have a list of solutions. So basically, you look at what is the best option and then do it. If it doesn't work, go and choose the next best, and next. It's a loop. You do till the problem is resolved. So it's a very effective technique for problems which are circumscribed and limited. And it's very simple to do, 6 steps, that's it. There's another one called crisis intervention, and that happens in times of disaster and so forth. And in the past, this was done extensively after any disaster, especially in the other countries where they had enough psychologists. So if people are overwhelmed by stressful events, first step was to lower the anxiety and promote sleep. And they encouraged the recall of the traumatic event. Now, what happened was they later found that this was actually counterproductive, that if you do that too early, it worsened the patient's outcome. So actually, they now don't encourage crisis intervention immediately after the aftermath of a disaster. This psychological intervention, okay, not the intervention that you do for other things, social thing, that has to be done, like providing shelter and food and water and all that. That's an emergency medical treatment. All that has to be done, but you don't go in with a team of psychologists and ask them to ventilate. Because after 1 month, most of the people settle actually on their own, and there's no need for any further therapy. If you do this, you'll end up with a whole heap of patients and no resources to manage them. And that happened during the tsunami, actually, when a whole heap of psychologists descended on the country and wanted to do crisis intervention. So most of them were sent packing, actually. And we didn't have any long-term major traumas as such. People had, but not to the extent we thought. So people are resilient, so you must allow them to recover on their own as well. Everybody doesn't need intervention. And of course, these are the behavior therapies, and there are a whole heap of techniques, and the ones I have put listed here are the ones that you have to know, okay? So again, I'm not going into each of those today. So anyway, all the items mentioned here, you must know how to do as trainees. Important. So hopefully you have done at least one of each, or more than one is better. When I say exposure, we mean graded exposure, okay? And then we go on to the next therapy. So behavior therapy is used to treat symptoms and behaviors that are persisting because of the actions taken by the patient or people. And the CBT is, or CT as it was called, is to treat symptoms and abnormal behaviors which persist because of the way that patients think about the problem. So behavior therapy targets actions. Well, obviously it's targeting behavior. And cognitive therapy targets the thinking. So both together is very powerful. So that's what it is now. Nowadays, we don't do only CT or only BT. Well, only BT is done, but not only CT. We do CBT. And the thoughts and actions go together. And both are required for the same patient. Again, I won't go into details, so we can do that another day. So there's a behavioral analysis that has to be done. There's a graded approach, and experiments are done after the patient tries them out in practice. So these are the 3 main areas. So it identifies maladaptive thinking, and the thinking is challenged, and alternative ways of thinking are worked out and tested again and again. So that's the cognitive therapy in a nutshell. So basically, we use a 3-column record. Of course, you can use a 5-column record as well. I just put this up as a problem you might face. thinking about the MD means the part two. So automatic thought maybe, is it too much for me? I will never finish studying in time. I will fail the exam. I won't be able to face my family, all that sort of thing. Emotion would be anxiety and depression. If you put that into a 5 column, this is the next level. So you can see that the third column is now added. You are rating the emotion, which is 80%. And then the other one is the important one, the alternative thoughts, which will counteract the initial thought. Well, I worked hard for 3 years. Last time the pass rate, I don't know, it was 70%, but anyway, maybe 70%. It's anyway definitely over 50%. I'm better than the average candidate, obviously, because for more than the 50, you should be better. And then you rate your emotion again, and it should come down to 20. Well, it should. You can try this and see anyway. Yeah, so that's example of CBT. So you have a 3 column and a 5 column. And it's important to write it actually. If you try to do without writing, of course, Ehrenbeck didn't do any writing, he just did it with a chat. But of course, he's a very highly skilled practitioner. We are not. So we have to do the columns, okay? So if the patient can't do it at home, you have to do it with the patient in the therapy session. So you fill it up with the patient on a magic board, actually. It can be done on a magic board and say, okay, right, now can you tell me, and put it down and write it. So that's how it is done. And if you look at my room, there was a magic board there. I don't know, it's still there in the board. Okay, that was for that. I never got to use it very much, but anyway, that was the idea. Right, so there are other therapies which, of course, have come along. Everything changes. So these are what you call the third generation CBTs. So they all have acronyms, or ACT or ACT, acceptance commitment therapy, DBT, I think you know, dialectical behavioral therapy, SFT, solution focused therapy, and EET, emotion efficacy therapy. These are all newer therapies which are based on CBT. They are kind of shorter, not DBT is not shorter, but others are fairly short therapies that came into being. And so they are called the first wave is called the behavior therapies. Second wave is the cognitive therapy. And the third wave is the third generation CBT. Okay. First wave is actually the first generation, if you want to look at it like that. So if you look at the books, they will talk of, they won't call it first generation, there'll be third generation CBTs, right? MBCT, mindfulness-based cognitive therapy, mindfulness-based stress reduction, MBSR. They're all very highly effective, proven, with the scientific evidence is there. Sorry, there's a very interesting therapy that gentleman called Stephen Hayes, he spent 20 years on it before he published his book, actually. So he made it quite a thorough study before he put it to the world. So his first book was Acceptance and Commitment Therapy. And later, now I think the second edition, Acceptance and Commitment Therapy. So these are fairly important books, but I don't know whether you'll have time to look at these books now, but maybe after the exam. But maybe I can do a session on this therapy, but it can be quite useful with some patients. Very briefly, the premises that we are all living still in the Stone Age, when this caveman was chased by a saber-toothed tiger, like, they were always getting chased, so they had to run pretty fast. So they lived in a very stressful environment, and anything that spelled danger, it was the fight and flight reaction immediately. Mainly flight, I suppose, because otherwise they would die. But what happened was, now caveman is not very long ago, evolutionary terms, they are about 1 million, not more than 1 million years away anyway, compared to the rest of the evolutionary history. And what has happened? Our brain hasn't adapted yet to the modern world where there are no kind of saber-tooth tigers chasing us around. But of course, there are other dangers. So what happens is our minds are always in this fight-flight mode. And because of that, that leads to anxiety and depression. So that was the premise of ACT. So ACT helps to detach or get away from this mindset. So ACT has six components. It's called the hexaflex. You can start at any node, any point you can start. Okay, there's no, you have to start here and go there kind of thing. So again, I won't have time to go through all these six things. I will just look at one, which is called your observing self. Left corner on the left lower side, your observing self. And that is another term for mindfulness. Okay. So exercise that is encouraged or to show your observing self is called leaves on a stream. Slightly off. Okay. Leaves on a stream. So basically the person is asked to think and imagine that there's a stream. You don't have to go to a stream. You can do it anywhere. And imagine there's a stream flowing by and there are leaves, floating on the stream. And when you get these troublesome thoughts, you put your thought on the leaf and let it float by, And when the next troublesome thought comes, the same thing. So thoughts come, thoughts go, thoughts come, thoughts go. So in a way, it's teaching you to detach yourself as an observer from your thoughts. Thoughts are not you, two different things. So if the thoughts are not you, why do you get so upset about the thought? Let it go, Okay, so that's the idea of called the noticing self. So like that, there are standard exercises for each of these principles, which the therapist will go through with the patient. Okay, so it's an interesting kind of therapy, and it doesn't take too long. You can go through this in 6 or 7, maybe 10 sessions. And it's proven to be quite effective, especially in stressful and that kind of situations, even depression. And now they have even modified it for trauma. There's ACT for trauma therapy for people who have undergone childhood traumas. So there's ACT for everything now. It's kind of expanding into all psychiatric disorders. Right, okay. So there are other therapies which can be classified according to the number of people or the duration. You can have long-term dynamic psychotherapy. You can have group therapy. You can have marital therapy. Nowadays, we call it not marital therapy, but we call it couple therapy because most people are not married now, especially in the West. So the name is changed. So it's called couple therapy. And family therapy is still there because families still exist. So it can depend on the group. So there are so many other possibilities with therapy. You can do with one people, many people. And there are the exotic therapies as well, like drama therapy, which actually was done in Gaul when Dr. Harishchandra was there. Once a week he had drama therapy in Karapiti. So the trainees who trained there had this kind of entertainment or experience of drama therapy and hypno-exorcism as well, where he used hypnosis to exorcise the devil in a metaphorical sense. So unfortunately, all those entertaining therapists are no longer there. So you all have a bit of a boring life, unfortunately. But anyway, what to do? So let's see whether we can revive at least some of that flavor. Otherwise, psychiatry is interesting if you use all the resources, but it can become pretty boring if you use only pharmacotherapy. So anyway, right. we are getting to the end almost. I didn't cover everything. It was a kind of a idiosyncratic journey through the psychotherapies. So if you have a special interest in any one, just let me know and we will do a whole session on that therapy. Okay. Right. So we are coming to the end. Now the important question, what matters most in therapy? Is it the technique or the therapy or the person or whatever? And this is very important. A large meta-analysis, they studied this, showed that the determinant of outcome, the main determinant, was not the type of therapy. It was the therapeutic alliance that predicted the outcome. Okay. So it comes back to what Francis Peabody said. Look, whatever therapy technique you practice, it won't work unless you have a quality relationship with the patient. And doing that is the most crucial thing a doctor has to do. Okay. Without that, you fail. Even with medicines, because the patient won't take the medicines. That's the problem. Right. So let me end with Francis Peabody's words. The secret of the care of the patient is in caring for the patient. There's a double play on the word care. Okay, note that. I said that there was something that Francis Peabody didn't tell anybody when he walked out that day to give this lecture. He didn't tell his wife, he didn't tell anybody. He was only 40 or 41, but brilliant physician. And he knew that he was suffering from something that's going to kill him. He had self-diagnosed carcinoma of the stomach. He knew what it was. He had diagnosed it himself, and he was right. He had carcinoma of the stomach. He didn't tell anybody. He did not upset the family, and he did not upset the faculty. So he kept it a secret, and he moved to quarters near the university so that he could work to the end without having to travel from home. Gave another excuse to the wife, and then a few months later he was dead. But well, anyway, courageous man. He never told anybody. He didn't talk about it. Worked right up to the end, and of course his lecture became famous later. But now nobody knows about it. But hopefully all can popularize it again. So I would encourage all of you to read his lecture word to word. It's about 3 pages. And this is the most important thing. Do you care? And that will make the difference to the outcome. Okay. Right. So let me end there.